So this is our hospital. This is actually a very small hospital. Our hospital is 105 bed, uh, but it does a lot of work. It's only cardiovascular. We don't see any patient who does not have a cardiovascular disease. We do close to 2,300 bypass surgery, 2,300, 1,800 bypass surgery, 2,300 coronary intervention. We've seen 230 patients of PE last year, and we've done 140 intervention. Um, so, so question is, why do we care? This is the most important question when a new technology comes by, is why would I care to learn something new, get the burden on my team, get the burden on the financial system, the patient, the hospital. Why do we care? We care about this. So in 2008, in the United States, there was more people dying from PE than people dying from HIV, car accident, and breast cancer combined. And when they looked more recently, they look at patient who has acute PEs, they have around 11% mortality in 2 weeks. And if you look at patients who have massive PE, and we'll talk about what massive PE mean, those patients, if you have a cardiac arrest, resuscitation, 65% of them die. So those patients, if you have the same number in patient with coming with acute myocardial infarction, that's not really good. So that's why we care about this. The other reason we care about it is this. Does anybody know what this is by raising hand? Two. That's what I expect, because this, as a cardiologist, we don't see this. This is a patient of mine that was my second month on the job. 28-year-old gentleman comes in with heart failure on oxygen. He said, when you take the story that 8 years before that, when he was 21, he had a pulmonary embolism, blood clot in his lung. He was placed on Coumadin, warfarin, for 6 months and then sent home. And then after 6 months, they stopped it. That's what the guidelines tell you. 6 months of therapy. You don't have to check CT. You don't have to check an echo. You treat everybody the same. A year or two later, he's short of breath. He's oxygen dependent on 6 liters. He lost his job. His wife is the one who's working. So he came to see us, and we ended up doing a CT scan and a VQ scan. And this is something called CTEP, chronic thromboembolic pulmonary hypertension. This is very devastating for young patients. We send him for open surgery. This is his lung artery. That's called pulmonary artery endarterectomy. A big surgery. 4 weeks to 6 weeks in the hospital. He walked out of the hospital without oxygen. He was able to get his job back. But again, if we can get that not to be done more frequently by treating those patients early, that's the goal. That's what our goal is. So the other thing is, this is a very old trial. 1999 showed that patients who get diagnosed with PE, if you take all comers, in 90 days, 17% died. That is a very, very high number. You don't want your patient to have this, nor you want your patient to die. So when we look at a PE, not every PE is the same. And I think you've seen this before. You've had a PE patient who looks great. 2 days later in the hospital, they crash and die, and you don't know why. This is because when the patient have a blood clot in the lung, it comes from somewhere. Most of the time, it's the leg or the arm. It dislodge, go to the pulmonary artery and close it acutely. So all of a sudden, you have no flow. When you have no flow, what happens? The right ventricle dilate, you get a tricuspid regurgitation, you get your myocardial inflammation, which is troponin. You have a very low troponin elevation. You're not expecting the high one like a STEMI. And if you catch this patient here, you'll be able to treat them, save them, and just reverse the process. When the patients start having no flow going from the right side to the left side, when the heart function, when the left ventricle doesn't fill up, you end up having cardiogenic shock, and those patients were called spiral of death. They just die. The more and more you attend pulmonary embolism conferences, you will see this slide presented in almost every single conference. So this is what's important. This is something from a friend of mine, Dr. Sethi in Colombia. He he and his team worked on basically dividing this patient to what we call low risk patient, intermediate high risk, intermediate low risk, or massive PE. And in majority of this patient, you have 25 to 30% here, you have 5% here, but majority, sorry, 20% or 25% here, 5% massive, but majority of the patients, more than 40 to 50%, comes with the intermediate low risk. Those are the patient that comes in with quote unquote hemodynamically stable patients. Blood pressure is stable, but they come with a heart rate elevation of above 100. They come with a troponin elevation. They come with a CT scan that showed RV to LV ratio more than 0.9. Those are the patients that can either turn around and go to low risk or turn this way and get to really massive and sick patients. And you look at the guidelines still behind. There's a guideline that's being written now that should be published early 2024. And this is the European guidelines. What European guidelines is treating every patient, asymptomatic patient with thrombectomy is not indicated. But if you have patient, it's a 2B indication to treat patient with some kind of therapy, invasive therapy. So this is, again, I'm not going to go through any of those slides. The only one I want to talk about is the PITO trial. So that's 2013, 2012 trial. It really started us to think about, can I treat this differently? The doctor before me has described all of those. I did not talk about flare. It's different from back to the device. And we actually part of the high PITO enrollment right now. And there's a knockout PE, which is another trial that we are publishing this year. So this is the PITO trial. This is a very, very interesting trial that was published in 2014. What they looked at, they said, every patient comes in with submassive features. We're either going to treat them with heparin, like what we've been doing for a long time, or we give them IV thrombolytic. And let's see what happened. So what happened is there is a huge difference between the people who got placebo meant just heparin. They received just heparin in terms of the TPA. So almost 3 times the number of patients end up having hemodynamic compromise. So those patients are not stable. They are sick. But the problem is way more bleeding. But what that told us is that what we're treating those patients with heparin alone is not enough. So what option do we have? Let's talk about flash. I think we're here to talk about flash. There's other technology. There's almost 9 different companies right now trying to come up with a thrombectomy device. 9 different companies. All of them are now in trials. The only 2 available in the country are 2 of them. So we'll talk about flash at this point. And I'm not going to compare 2 thrombectomy devices because each one of them has its own unique features and usage. But for flash, so this is what flash is. See, the tip is different than CAT-RX, but it's also 16 French instead of the 6 French. I was corrected by the engineers. I used to call it AI based. It's not AI. I wish it is AI. It is computer based. What a computer tell you, are you in a free flow or are you in a clot? So it's 8.4 more powerful than the 24. Again, manual versus continuous mechanical, and softer. The Inari device is a 24 French. I've used it in a lot of cases. I've used flash as well, and I think each has its own unique features. So what the flash provide you is different curves. Those are secondary catheters that you can put inside. Those are 5 French, 125 centimeter. And even the catheter has either a single curve or double curve. This is just an example to show you, patient taking a picture, wire, you have no flow here, and now you have a flow with the flush. This is the clot you get. This is going to make noises. I'm not sure how loud it is, but this is just show you the different light and the different computer. The solid green is based. Oh, good. It doesn't make a noise. Good, but it has a clicking noise to it. Can you put a noise on? Can you put the volume up? So the green, it means it's sampling to see if you are in a flow, if you are in a free flow or you are in a clot. And then the solid yellow means, hey, you are in a clot or you're against the wall. And solid yellow, but then you have this continuous noise. We're going to hear it. But continuous noise is called the flash mode, which is like instead of a tick, 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 it's going to go back to back. Tick, 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 tick. That means it is detecting the clot and it's activated. And then sometimes you have a flashing yellow. That means you are in a clot, but you're not able to suction the clot. So you have to come back, pull it back, and advance again. It has a learning curve to it. So I would really make sure that at least the first 10 to 15 cases you have the company rep in the room to kind of guide you a little bit, and eventually you'll be able to make your own judgment. But you see how solid yellow it detected the clot and how to flow through it. So if you notice this one it was yellow, flash mode, and then green, then you stop. That means you already got the clot out. So you don't have to continue suctioning, otherwise you end up having a lot of blood loss. So the Strike PE is an important trial. It had a 90-day. It was published twice actually so far as an interim analysis. It had the 30 days and the 60 and the 90 days analysis. And the recent one was in TCT. And this is the trial that we'll talk about. It's a global trial. It's 600 patients. It's looking at patients to try to see if we have a good outcome with this patient. And the problem with this one, when it started, was people were using the 12. Now we have the 16. So the first 150, majority of those patients had the device that was a 12 French. Again, was discussed before. This is what you're looking at. All these trials looks at an RV to LV ratio because we know from multiple trials before that if you have a bad RV when you leave the hospital, you have a significantly higher mortality. And of course, they look at safety point at 48 hours, and then what they added, which is important, is the quality of life metrics because you guys have seen patients who had a PE come back 6 months later and they tell you that they never feel the same as they were prior to having the PE. And when you look at the interim analysis, the thrombectomy time is really not long. It's around 33 minutes. So if you look at it from a procedure perspective, one of the things people complain about it is that is this going to be a very long procedure? You know, in coronary, we're now so good at it. You guys are all great interventionists. You are very good doing coronary intervention. The question is, am I adding something that's taking a longer time? But the more and more you do it, you don't have you'll be faster at it. No ICU stay in 38% of the patient. RVLV ratio has showed significant improvement, with a baseline being 1.33 to 0.98. Major complication is 2.7%. Device-related serious adverse effect is 1.3. Recurrent PE is 2. This is the PA pressure. This is something I would recommend if you're going to start a PE program. A couple of things. One is to make sure you have a team with you. Don't do it by yourself. It's a lot of work. 2 is get a PA pressure before and after. It will give you a guidance that if you've done enough or not. Always discuss before. Oh, this is important just to show you that on a different metrics of quality of life at 90 days, there was a significant improvement with doing thrombectomy. So this is what basically speed, safety, and simplicity. So speed, this is from the trial. A friend of mine, he's a head of Cooper University Cath Lab. They're so quick and they're so efficient with it. Their average is 12 minutes. I mean, I don't know how he does it 12 minutes, but it's for us, our numbers around 22 minutes thrombectomy time. Or still not, it's very safe. We talk about the risk. Very durable. I mean, you can really easy. You can clock and counterclock. You can go to different lobes and different directions, which I think is one of the unique features of this device. So I'm going to go over a couple of cases, and we'll finish up there. So this is a 54-year-old male with no past medical history, and the more and more you treat pulmonary embolism, you will see that you're treating younger and younger patients. With the last patient we did last week was 25-year-old female. My youngest patient is 18. So had a COVID-19 2 weeks ago. He came with shortness of breath for 3 days, and in the ER he was hypoxic. His oxygenation level was in the low 80s, and his heart rate was in the 110 to 130. This is the AKG. This is the AKG that you, as a cardiologist, you may get called about sometime before you diagnose with a PE. But from the story, you can tell this patient have a high suspicion of PE. So if the doctor tell you have this patient young, short of breath, this is the EKG. The two things you think about, or three things you think about myocarditis or pericarditis. You think about PE, or you think about heart failure or non-cardiac related issue. And this is the echo. I mean, it's always good to give those talks to cardiologists. Nothing harder than try to explain echo to a vascular surgeon. But this is an echo. This is the CT. You can see the saddle PE right there. And then this is the echo. And you see, it's actually the RV doesn't look bad. The reason I show this one is because this is where you have to teach your echo sonographer how to get a real echo. This is actually a very short axis echo. So actually the RV was not fully assessed in this. But if you do the right echo, you see the RV is significantly dilated. So the things we look at when we look at a CT scan, and I don't know how much different audience here has experience with PE therapy, but on the CT, there's a couple of things we look at. We look at the size of the PE. We look if it's saddle versus if it's from segmental. We look if there's an infarct. It's extremely important. So we look at the lung view and we look if there's any infarct, because if there's an infarct, there's certain things you need to think about and treat differently. And on the echo, of course, RV-LV ratio is exposed. I know you do the RV to LV ratio on the CT as well. And on the echo, you look at RV-LV ratio. The second thing you look for is LV function, because this is the question that comes up a lot when I give talks in the United States is when should you use ECMO on those patients? And the last thing is something called clot in transit. This is the case in the patient. These are still frames. So we went from the groin, and I'm happy to go over step by step how to do the procedure. But we go from the groin. We put a pigtail. That's our favorite catheter. We take manual injection. You can see clot extending all the way down here. This patient came actually to the cath lab on a 35 liters a minute on oxygen. And when we get the pressure, initially was 27, mean PA pressure 27. So not super bad. And then this is post-thrombectomy. See, almost all the clot are out, and you have a nice flush in the lung. And this is the left side. You see the clot right, the white part there. That's a clot. I call it the ghost sign. And after you take it out, you have a nice flush, and that's selective angiogram. The PA pressure went down to 15, and the patient left the cath lab on 4 liters of oxygen instead of a 35. When you look at the thrombectomy, a couple of things to recognize is one, there's dark red clot. Those are acute clot that happen over the last, few days. And then you have this white clot that happened over the last 14 days or longer. And those patients usually don't come in right away. They have a leg discomfort, they ignore it, it gets swollen, it's get discomfort, they ignore it again. I don't want to go to the hospital, get short of breath for a day or two, and then they come to the hospital. It's very rare to see someone who had a leg discomfort, shortness of breath, and come within 24 hours. So it's not uncommon to see a lot of this chronic clot buildup there. And it depends on the device you use, flash 8, flash 12, or flash 16, or other thrombectomy devices, the 24, the clot will look different. The way with this device works, it's continuous suction. So it will dry the clot, become smaller and smaller and smaller. So you may see a picture of, for example, Inari thrombectomy with a bigger clot. That clot still have a lot of saline in it. It's the same exact clot when you dry it out, keep it on the side for a while, it will shrink down and become smaller. It's the same clot you're taking in different modality, but it looked different because here it's continuous suction, pulling all the fluid out of it. Case 2 is a little bit more challenging. It's a 77-year-old female, and coronary artery disease. She had a heart failure, and her ejection fraction recovered with medical therapy. She has all the other risk factors, and she came in with shortness of breath for 6 days. The first thing they thought about it is heart failure again. Her PESIS score and simple PESIS score, and those are scored to tell you how high or intermediate risk those cases are, and you can get them. There's apps for them for free. They were in the intermediate to high risk. Her again, blood pressure is stable, heart rate is a little bit up, respiratory rate is a little bit up, statin a little bit low on room air, and 94.2 liters. What's going to happen is the ER doc is going to call you and say, I have someone, I expect PE, they're stable. That's the statement they're going to say over and over. This is not a stable patient. That's relatively stable patient. But this patient can get really sick. Troponin is elevated, BNP is normal, and venous ultrasound showed a DVT. This is the echo. It's not as impressive. This is the CT, and it's not as impressive as the other CT. You don't see saddle PE. What do you see? You see clot, a close-up clot here on the right upper. You see something here in the middle, and you see something on the left. So not really terrible. So the physician, this is the echo. That's where this is really bad echo. That's the RV to LV ratio is 1.2. This is McConnell sign. That's RVSP is super high on echo. This patient is sicker than what they look. So day one, the team was on one of my partners were on service. He said, well, you know what? It's a small clot burden. Let's just treat patient with heparin and see how they do. Let's not get her through intervention. I'm hoping heparin will just do fine. And day two, we said, let's go walk the patient. Now she's 24 hours on heparin, and she dropped her oxygen on dropped her O2 sat on oxygen to 84%. This patient is really not fine. This patient is sicker than what they look. So we decided let's go ahead and proceed with mechanical thrombectomy. This is step by step how we do it. Again, this is just not a mandation. This is just a recommendation. You can do it a different way. We do ultrasound guided right common femoral vein access. You can use the left. You can use the IJ. Stiff wire. We advance it to the SVC, and we advance 16 by 33 Gore sheet. The other option will be 16 by 65. You can do 18. You can do the Cook. Doesn't really matter. 16 or 18. We always like to cross the tricuspid valve with a pigtail or a J-tip wire catheter, or pigtail or the balloon wedge catheter. And we use the soft wire called a baby J to cross the tricuspid to the pulmonic artery. And then we will switch with a stiff wire, Supracore or Amplats, whatever your preference is. And then we advance the penumbra catheter, and then we check PA pressure first. In this patient, mean PA pressure was 33, so that's moderate, severe pulmonary hypertension. And what we went to the left upper first because that's where the wire went. And majority of the time, when you go from the right groin, the wire will go to the left side. And now we start doing recently is we try to go to the right side first. It's harder to get to, and then you pull the catheter and we'll go to the left side. And then the interesting part is, and that's something that it took us a while to learn, is in the penumbra flash 16, we take the wire out when we suction, which is different than what we learn as cardiologists. Never lose the wire. It's actually, when you take the wire out, you have more ability to maneuver the catheter and have better suction. So went into the left side, we took the clot out, not much, and went to the right side. So when we went to the right side, this is the left, this is the right side. Again, the PA pressure has not changed. So mean PA pressure is still high. And if you look at it, there's a clot sitting here, and there's a clot sitting right in that right upper lobe that's occlusive. So we took this clot out first, and then we took it out. PA pressure maybe went down a little bit. So this is when you took it out, you have a nice flow there, nice flush. Not much. So the only clot that we have not taken out and the mean PA pressure is still up is this occlusive clot in the right upper. We went in and we took it out, and you see the mean PA pressure dropped right away, back to normal. And this is the clot we took. All kind of acute. There's maybe a little bit of a chronic here. Very small clot. So the reason I present this case is just saying the clot size doesn't matter. I think that's incorrect. As you guys know, we treat patients, we don't treat clot. So if a patient looks sick, doesn't matter how small the clot is, maybe that's something you need to go in and do it. We do that in the coronary all the time. Sometimes patient comes in with the OM2 lesion that you say let's treat with medication, but the patient continues to have chest pain. You come back and fix it, even if you have to go to 2.5 stent. The same thing here. So just having a saddle PE doesn't mean you have to treat it. Just having an segmental PE, that doesn't mean you should not treat it. So I would recommend just make sure you have your steam and just make sure you have a plan. And I really recommend over and over, get a PA pressure, make a huge difference. That's it. Thank you.